topic for discussion is glaucoma drainage devices. I'm Dr. Simi Mary George, secondary DNB PG first year, and this session is moderated by Dr. AP ma'am. Glaucoma drainage devices are designed to shunt aqueous from the anterior chamber to a space maintaining plate in the equatorial subconjunctival space. A small flexible tube made of biocompatible materials, silicon or polymers, paired with the plate. One end of the tube is inserted into the anterior chamber. The other end is connected to a plate in the space between conjunctiva and sclera, which creates an alternative pathway for aqueous drainage. Physiology. Insertion of the glaucoma drainage implant is preferred in the supratemporal quadrant. After 1 month of implantation, a thin collagenous capsule surrounded by granulomatous reaction occurs. 4 months after implantation, the granulomatous reaction resolves, the capsule thickens, remains relatively stable, collagen stroma becomes less compact. Aqueous passes through capsule via passive diffusion and is absorbed by periocular capillaries and lymphatics. Final IOP is determined by capsular thickness and surface area of encapsulation. These are the indications for a glaucoma drainage device, mainly refractory glaucomas, failed trabeculectomy, neovascular glaucoma, eye syndrome, post-PK glaucoma, post-vitreoretinal surgery glaucoma, traumatic glaucoma, aniridia, and uveitic glaucoma. Coming to the history, it began with the early Saturn era from 1906 to 1960. Satins are solid structures used to wick the aqueous humor from anterior chamber. It began with Rowlett using horsehair to drain the aqueous humor via paracentesis. Even sutures, glass, metals, plastic materials were used, but the satins eventually failed due to inflammation, fibrosis, and infection. Next comes the Moltener revolution, which began from the 1969 to 1970. Dr. Anthony Moltener introduced tube shunt implants. The plate was implanted posterior to the limbus, which was connected to the anterior chamber by long silicone tube. These were non-restrictive implants and consist of single plate, double plate, a pressure ridge, and pediatric versions. Next comes the valve era, began from 1970 to 1980. Dr. Theodore Krupin in 1976 designed an implant with pressure-sensitive slit opening in the tube, which was a unidirectional valve but was prone to occlusion by debris. Next comes the modern glaucoma drainage devices development from 1990 to present. It began with the Dr. George Beerwold introducing the Beerwold implant in 1990, which was a non-restrictive implant which had larger plates and softer silicone materials, followed by Ahmed glaucoma valve in 1993, Ahmed ClearPath in 2019, and Paul glaucoma implant. Types of glaucoma implants based on the type of plate are classified as rigid and flexible, based on the type of material into silicone and polypropylene. Silicone implants basically Ahmed, Beerwold, Krupin, Orolab aqueous drainage implant, Ahmed ClearPath, Paul glaucoma implant. Polypropylene Moltener and Ahmed. Based on type of opening, they are classified as valved and non-valved. Valved are basically Ahmed and Krupin. Based on the type of opening, they are classified as valved and non-valved. Valve consists of Ahmed and Krupin. Krupin is not available commercially. Ahmed glaucoma valve is the only valve device which is being used now. Non-valve consists of Beerwold, Moltener, Orolab aqueous drainage implant, Paul glaucoma implant, and Ahmed ClearPath. Moltener implant is a prototype of the GDDs, which is made of polypropylene. It comes in single plate and double plate. Moltener implant offers no resistance to the outflow and results in complications like hypotony, flat anterior chamber, and choroidal effusion. Next comes the Shocket implant. It consists of a celastic tube or a silicone tube extended from the anterior chamber to 360 degrees encircling silicone band. It functions as a reservoir for aqueous drainage. With it requires intra-op assembly and needs ligature or stent. Next comes the bare walled implant. It is available in 350 millimeter square surface area and 250 millimeter square surface area. 500 millimeter square surface area is not available now. It consists of a silicone tube and the end plate is barium impregnated rounded silicone plate with fenestrations. Site of insertion is basically in the supratemporal quadrant under the recti muscle insertion. Features are it consists of a large surface area of the plate and it is designed in such a way that they can be easily implanted through a one quadrant conjunctival incision. The end plate has fenestrations that allow the fibrous bands to grow through the plate, serving to reduce the bleb height and secure the implant in place. You are not mentioned how far it is fixed away from the sclera. When you fix this non-walled implant, how far the plate will be fixed from the limbus? 8 mm from the limbus, ma'am. Is it 8 to 10 mm? 10 to 12, will it be possible? 12? 8 to 10. 8 to 10 mm. They say 9 to 10, not very far. Okay. And what about AGV? Ahmed? 8. 8 to 10.
Yeah, and one more question. She said about the 500 square millimeter implant. Why is that no longer used? The larger the surface area, the better the filtration, but...
More chances of complications like hypotony, diplopia.
Yeah, that's one. And if you make something bigger than 500, do you think that would be helpful?
No more filtration.
Yeah, there's not going to be any more filtration. So they found that something more than 500 is really not going to be very helpful.
Orolab aqueous drainage implant. It's designed like bare walled implant and it's non-valved. It's a barium impregnated silicone plate with silicone tube. It has 2 fixation holes. The large surface area of 350 millimeter square, a single quadrant incision with a flexible tie-off capability in the tube. It has a unique fenestration design. This is a video showing an external ligature in Orolab aqueous drainage implant.
The fellows, why is it barium impregnated? Yeah. In X-rays it can be picked up, correct.
Coming to the Ahmed glaucoma valve, it consists of a plate made of medical grade silicone with an area of 184 millimeter square, a drainage tube composed of silicone with an inner diameter of 0.317 millimeters and outer diameter of 0.635 millimeters. It has a valve mechanism that has 2 thin silicone elastomer membrane, 8 mm long and 7 mm wide, which is held under a tension, creating a Venturi-shaped chamber. It follows the Bernoulli's principle where the inlet cross-section is wider than the outlet that enables the valve to remain open even with a small pressure difference between the anterior chamber and the bleb dome. Priming of the AGV is done prior to the implantation to separate the valve leaflets. The valve is designed to open when the IOP is 8 to 12 millimeters of mercury and closes when the desired pressure is reached. These are the elastomer membranes. The various designs, FP7 Ahmed, S2, pediatric version S3, then a double plate. No touch zone in Ahmed glaucoma valve. The area of the implant covering the chamber with the silicone leaflets. If the implant is grasped with the forceps along the central line, it may separate the valve cover from the implant, and the external pressure on the valve chamber can cause a defect in the valve closure. It results in early postoperative hypotony and fibrovascular membrane ingrowth between the leaflets, and this lead to valve failure due to the adhesion of the valve membranes. Contraindication: eyes with severe scleral or scleral limbal thinning, extensive fibrosis of the conjunctiva, ciliary block glaucoma. Relative contraindications: vitreous in the AC, intraocular silicone oil. If implantation is required, it is done in the inferotemporal quadrant. Preoperative evaluation is done. It needs the patient counseling on the nature of the disease, possibility of needing a second surgical procedure to tackle implant-related complications. Pre-op evaluation, we have to assess the potential for useful vision, a preoperative IOP, upper lid position, scleral exposure, tear film stability, blepharitis, corneal clarity. In pseudophakic eyes, we have to measure the depth. We have to see the anterior chamber depth. Post PK eyes, endothelial cell function, vitreous strands in AC, cataract, agonioscopy to rule out PAS, peripheral anterior synecdoche, and neovascularization at the angle. Avoid supranasal quadrant to reduce the risk of strabismus and diplopia. Plan an inferior placement in silicone oil filled eyes. Pars plana placement in cases with peripheral anterior synecdoche precluding the placement in anterior chamber. Thus, preoperative evaluation enables us to control the IOP and control the intraocular and conjunctival inflammation. Surgical techniques for valve devices. We have, there is a step known as priming of the implant, where a 27 gauge needle is used to inject balance salt solution, and we have to see the 27 gauge cannula, and we have to see the flow is in balance salt solution is injected through the tube, and we have to see the flow of the stream, followed by a conjunctival based incision. A pocket is formed between superior and lateral rectus. Placement of the implant, where the leading edge is placed 8 millimeters from the limbus. Tube is trimmed with the tip, with the bevel up, and the bevel is cut at 30 degrees. A paracentesis is made superiorly using a 23 gauge cannula, and entry into the anterior chamber is made. Insertion of the tube into the anterior chamber is made, where the tube tip enters into the anterior chamber by 3 millimeters, followed by scleral patch graft over the tube to cover it over the limbus, followed by closure of the peritomy. For non-valve devices, additional step is isolation of the recti using muscle hook. Ma'am, conjunctival peritomy is done, and we are trying to separate the tenons from the sclera using a blunt viscot. And here we are priming the AGV with balance salt solution. We are tucking in the plate in the pocket made between the superior rectus and lateral rectus. We are anchoring the plate onto the sclera using two stage sutures, 10-0 nylon and
9-0 nylon.
Where the tube entry is made?
using a 23 gauge needle, a scleral track is placed, and
What is the patch graft is this? What's her name?
partial
Huh?
thickness.
Partial thickness what?
Corneal patch graft. After making the needle track, the tip of the tube is cut with the bevel up and is introduced into the anterior chamber, so that 3 millimeter of the tip of the tube enters the anterior chamber. Then the tube is fixed with the tensor nylon using a X-shaped suture. Then partial thickness corneal patch.
Everything is 9-0 nylon.
9-0 nylon.
Have you seen the procedure?
Only one.
How many glaucoma posting you have finished?
One.
Only one. And you have not seen AGV?
Only one.
Huh. You have not seen any AGV procedure?
Only one.
See, you had a class, you could have taken extra effort, went and seen the procedure. Now, unless you see, how you will describe it to others? I think half of the things you are not, I don't think, is it prepared by you?
What kind of peritomy, what kind of incision is this? Fornix based or was it limbus based? Was it a limbus based incision or fornix based incision?
Modifications to prevent hypotony in non-valve devices. Internal tube occlusion or stent has been introduced. The aqueous drainage is regulated by passing a 40 or 50 proline or nylon suture through the lumen of the implant. Once the fibrous capsule around the plate has formed, the stent suture is removed. External tube occlusion or ligature. A suture ligature is placed around the external aspect of the tube, as we have seen in the previous video of Orolab aqueous drainage implant. A non-absorbable 7-0 suture with a releasable knot or a 7-0 or 8-0 absorbable Vicryl suture is tied around the tube, or alternatively a 9-0 nylon or 10-0 proline may be used to ligate the tube inside the anterior chamber to allow for later suture lysis with the argon laser. Vending slits made anterior to the ligature suture with either a needle or a knife, which allows immediate IOP control in the post-operative period. Next comes the two-stage procedure. In the first stage, we implant the plate without insertion of the tube into the AC, and the tube is tucked beneath the conjunctiva. 4 to 6 weeks, the capsule develops. In the second stage, we insert the tube into the AC. That is after 4 to 6 weeks. Materials used to cover the tube. This is to minimize the tube erosion, and it includes the partial thickness scleral flap, scleral patch graft, clear corneal patch graft, donor pericardium or tutoplast, donor facial latter, dura mater, bioengineered porcine mucosa, amniotic membrane, buccal mucosal membrane, autologous tragal perichondrium. Hypertensive phase, which begins in the 3 to 6 weeks up to 6 months, and there is a temporary rise in IOP of more than 21 millimeters of mercury, peaking within the 3 months due to congestion or edema of the fibrous capsule around the plate, followed by a stabilization phase for the 3 to 6 months where the fibrous capsule matures. The inflammation reduces, the IOP stabilizes due to tissue remodeling, and the device starts to function consistently. Coming to the hypertensive phase, it is related to the dense fibrous encapsulation due to early exposure to the inflammatory cytokines in the anterior chamber. This is most commonly after insertion of the AGV, but it is seen with all types of glaucoma drainage devices, including the Molten and Bevold. Nori et al. In their study demonstrated as many as 72% of the cases, the elevated IOP did not resolve, and they concluded that the hypertensive phase may signal towards an early device failure. Earlier initiation of glaucoma therapy, particularly aqueous suppressants, may be effective in reducing the rate of hypertensive phase and the magnitude and duration of IOP rise.
So hypertensive phase occurs in non-valved implants also, but they will occur at a later time when the aqueous has started to pass through the tube. And usually the hypertensive phase occurs a little earlier in non-valved implants because the bleb is already thickened, and once the inflammatory mediators pass through, it becomes more thicker. Usually 10 to 15 days after the ligature has opened up, this can be seen. So it is seen in non-valved implants also, but more commonly with.
So we manage the hypertensive phase using the aqueous suppressants, digital massage. If it is not getting resolved, we go for a subconjunctival injection of the antimetabolites like mitomycin C or 5-fluorouracil in the fornix away from the bleb, or bleb needling with a 30-gauge needle, suture lysis for non-valved implants, or a revision of surgery by placing another shunt or removal of the cyst wall and use of amniotic membrane. The reasons for failure of AGV: early post-op flow leading to a thick-walled bleb and hypertensive phase. So the early flow may result in an imbalance between the fibroproliferative and fibrodegenerative process required to create a thin avascular bleb. So here both are made up of silicon, so AGV may be more inflammatory, even 10-fold greater than the bare-walled implant. Coming to the complications, intraoperative complications, hyphema, lens and corneal endothelial damage, scleral perforation, retinal tear and hypotony. Early post-operative hypotony, ligature release in non-valved implant, corneal decompensation, overhanging bleb, conjunctival flap retraction.
You can go to the next.
Early post-operative complications, hypotony is a very serious complication of open non-valved implants until the fibrous capsule forms. It is managed using topical cycloplegics and steroids, then use of viscoelastic agents if the flat chamber develops, followed by systemic steroids. It can be prevented by occlusion of the tube by suture ligation, using absorbable polygalactin suture, temporary occlusion with a stent, and a two-stage implantation. Choroidal effusion, it is the most common retinal complication. It occurs when no method of restricting outflow used after surgery, or the tube is opened by dissolving suture or manipulating stent. It is crucial to perform a dilated fundus examination and close monitoring. Avoid heavy lifting, bending, straining, or any excessive exercise. Serious choroidal effusion usually resolve spontaneously. Coming to suprachoroidal hemorrhage, risk factors include older age children, prolonged hypotony, choroidal effusions, high myop, aphakia, multiple surgeries, hypertensive patients, and atherosclerosis. An incidence of 4.2% with various implants with a bimodal distribution in the immediate post-op when the tube is opened 4 to 6 weeks after the suture dissolves. Management, non-surgical, topical or oral steroids, topical cycloplegics, surgical, drainage of the suprachoroidal hemorrhage via radial sclerotomies. To maintain the IOP, we can inject viscoelastic and balanced salt solution. If the suprachoroidal hemorrhage is associated with the retinal detachment of vitreous hemorrhage, the suprachoroidal hemorrhage is drained with a vitrectomy or a plus an add-on vitrectomy or a scleral buckling is done. Tube exposure with an incidence of 5 to 15% is due to conjunctival erosion or patch graft melt, which increases the risk of endophthalmitis. Charco et al. States that the risk factors were younger age and inflammation. This tube exposure needs a surgical repair where a patch graft with conjunctival advancement or conjunctival patch graft is done.
In which patients do you see there is more risk of tube exposure? Yes. Inflammatory glaucomas? Okay. When you have had multiple conjunctival surgeries previously, they are all again at a risk of conjunctival erosion. And patients who have been on topical steroids or systemic steroids for long, again in them also, you will see that the conjunctiva melts early in them.
This is the reepithelialization over the corneal patch graft.
This is what I was talking about. When you have a corneal patch graft, even if there is a conjunctival opening, you will be able to see that there is vasculature developing over the corneal patch graft. So these will not require repair. Okay, but in a scleral patch graft, we will not see this. So this is again an added advantage of corneal patch graft. You can see that there is a conjunctival defect over the cornea, but still there is epithelialization over that. And there will be no leak.
Complications, tube lens touch, corneal decompensation, tube retraction, and tube blocked by vitreous. Studies and clinical trials. 5-year treatment outcomes in the...
Go back to the previous slide. Okay, fellows. Where are the other fellows? Tell me all the landmark trials related to implants. PGs, you can tell me. Just name the landmark trials.
On the tube versus trap and the primary tube versus trap, in which in the tube versus trap there is there was a procedure involving the conjunctiva that had already been performed. So they, to analyze the outcomes more properly, they, in the primary thing, they took the fresh conjunctiva which had been untouched.
In the PTVT study, you're telling. Okay. Do you know the results of the study, TVT and PTVT study?
It's just, it was almost similar in both of them.
Which study you're talking about?
The PTVT. It was almost similar in both of them. The IOP control, it was like the long-term effect was better with trabeculectomy as compared to the implant.
What was TVT study?
Tube versus trabeculectomy. Not very definitely I remember, but one was, it was done primarily, both the surgeries, like a primary surgery, glaucoma surgery will be trab and primary surgery will be tube. And in
Which study you're talking about now?
In PTVT, and in TVT, it was secondary surgery. It
failed
was
trabs.
Failed trabs when we put the tube.
Which implant they're talking about in the TVT study?
Bearwelt implant only they put in.
Bearwelt implant compared to trabeculectomy. Which fared better, the trab or the implant? They wanted to know, because implants had come into the market at that time. They wanted to know which surgery was better in these patients. Okay, that was a very significant trial which modified the treatment in many parts of the globe with the results. Okay.
In TVT study, they have their inclusion criteria is previous intraocular surgery or previous failed trap will be included in the study. 8 to more than 18 years of age, and they excluded neovascular glaucoma and uveitic glaucoma, and cases which had high risk of failure of trab like superior conjunctival scarring. All these cases were excluded in TVT study, and in their results at the end of 5 years, tube fared well. It was around 29% was a failure rate compared to 46% in trabeculectomy surgery, and the reoperation rate was also less in tube surgery, whereas in trab it was around 29 and it was tube, I don't remember, it was less. Reoperation rate was also more with trab study, ma'am. So they concluded that tubes are better in TVT study. In PTVT study, primary surgery was either tube or trabs. In that, trab favored well, and trab has less rate of failures, ma'am. Next study.
So why do you think the TVT study showed that the tube was better? Did you find any flaw with that? Do you really think tube is better than trab? No. Why do you think so? What was the amount of mitomycin C they used?
0.4 mg for 4 minutes they have used.
Do we use for 4 minutes?
No.
So that is why they had more patients with hypotony. So even if there was a leak, they had labeled them as complications. That is why the rates of complications were more with tubes. So after this study came out, there was a major change in primary surgeries. They would do more of tubes, but in many parts of the world. But then the real world scenario, we know that trabs fare better than tubes. That is why they wanted to know whether really the tube is a better option than trab. PTVT study came out. So compared to the valved and non-valved implants, which do you think is better?
The study state that Barweld ABC and AVB both state that Barweld had higher success rate compared to AGV, but failure rate due to hypotony was more with Barweld compared to Agamanth glaucoma valve.
So then now, which do you say it is better? So both the ABC and the AVB came out with almost similar results only. So if you need a lower intraocular pressure, which implant you want to choose?
Glaucoma.
If you want a safer implant, what you want to?
AGV.
But then pressures also will be?
Around mean reduction was at the end of 5 years was 17, and in Barweld it was 14.
Okay, so okay, you can go ahead. I think it is the same. You just go through the gist of it.
5-year treatment outcomes in the Ahmed-Bewold comparison study and the Ahmed versus Bewold study. IOP ABC versus AVB. In ABC, 276 eyes were enrolled for the study, and AGV was implanted in 143 and Bearwalt in 133 eyes.
Just go through the slides only. Don't keep reading it.
This is the survival curve showing the success criteria of ABC and AVB. Reoperation rate. In the ABC study, AGV required 20.8% reoperation. In AVB, 51% required reoperation. In ABC study, the reason for failure was found to be inadequate IOP control without any additional glaucoma surgery and reoperation to decrease the IOP in Ahmed group. And in AVB, it was high IOP and de novo glaucoma surgery in Ahmed group. 5-year pool data analysis of ABC and AVB study. When comparing the devices, the Bearwalt had a lower failure rate, lower rate of de novo surgery, and provided a lower IOP on fewer medications at 5 years, but had a higher risk of hypotony.
Just look at the number of patients who had hypotony in the Bearwalt group compared to the AGV. I think if you severe visual loss, one slide will be there. It is here only. Okay.
Severe vision loss in Bearwalt 7%, and in Ahmed it was 4.9%, 13.
Okay.
Treatment outcomes in the primary tube versus trap.
You just go to the results only.
Patients with low pre-op IOP do poorly with tube shunt surgery as a primary procedure. The trap with MMC had a higher surgical success rate than the tube shunt implantation after 1 year in the PTBT study.
So this is just maybe you all can take it so that you can revise for exams. Go.
GDDs in special situations like post-PKP, eye syndrome, in pseudophakia, pars plana entry, it is mandatory to do a complete pars plana vitrectomy with base excision. Implantation through PI, then ciliary sulcus implantation, sulcus placement of the tube with an iridectomy window. AGV with hazy corneas require a light source.
So in such a wide cornea, when we have to do an implantation as a last resort, you will not know where the tube is entering, where the needle track is going. Okay, you can make use of the light source. You can make out approximately the anterior chamber depth. Okay, I don't know if you can appreciate where the tube is going. Can you see? Yeah.
The use of Ahmed glaucoma valve in the management of pediatric.
So that was a case of congenital glaucoma who had 3 failed trabeculectomies, external traps. So ultimately we had to do a AGV implantation. So how does AGV fare in pediatric glaucomas? So pediatric glaucoma is a refractory glaucoma. It's a severe glaucoma. So how does it fare in that? This is an implant which is going to stay in the eye for very long time, not in like in adults, right? So if we have implanted the AGV at the age of some 3 years, for another 60-70 years it is going to stay in the eye. So it can cause a lot of problems, lot of complications. So this was studied by BS ma'am. Yeah, go through that. So actually it was fellows, you must be knowing about it. Can you describe? No, I'll rush through. Read or not read? It was categorized into 3 categories. Okay, primary, congenital, and juvenile, like with phakic. The second was aphakia and pseudophakia. The third was secondary glaucomas. The majority was in patients glaucoma following cataract surgery. So aphakics and pseudophakics. So this is a survival analysis. If you look at it, what can you understand, Amruta?
100% of the children had a successful surgery, whereas the same group in 2 years there was a dropout and only 82% of them had success. Similarly, in group 2, in the first year follow-up, it was 95%, and after dropouts and after 2 years, it was 86%.
You look at the graph and tell me what has happened later afterwards. 3 years, 4 years also, no? The success does come down. It does come down. That is what you have to understand, okay?
EGV neovascular glaucoma, with the tube placed in the sulcus, it's more prone for post-op inflammation.
No, that is because it is a neovascular glaucoma eye, which is more prone for inflammation. That too, when you are trying to put the tube in the sulcus, which is a very vascular area. Okay, sometimes we retain the viscoelastic also so that the patient doesn't go into hypotony. That also causes amount. So this was a sterile inflammation. So post PK eyes also, the most preferred site is to stay away from the cornea. But if it is phakic, then you will have to put it in the AC. So there is a risk that the graft can decompensate. So that will be there even if the tube is not closer to the cornea. So what is critical angle?
AGV in
So eye syndrome is a condition where implants usually, you will decide to put an implant usually in very refractory glaucomas. Okay. Primarily, if you are thinking about putting a tube, it is in very few conditions where you will think about putting a tube. Otherwise, it's usually a failed trap. One trap, it has failed, or twice it has failed. Only then you will think about putting a tube. So, few conditions you will primarily think about putting a tube is one of this condition. Okay, whenever you see an eye syndrome. But even then, if the anterior segment is not that distorted, the iris is not showing a lot of changes, we will still try to do a trab only in these eyes. If it is quite you have extensive ectropia on UVA, you have peripheral corneal degeneration only, then you will think about putting a tube. You can rush through that, just show the pictures maybe for their understanding. So eyes is a progressive condition. The iris will be pulled anteriorly because of the fibrous membrane. So if you put it in the anterior chamber, the tube will migrate anteriorly and come closer to the cornea and cause corneal decompensation. So that is why tube should be in the sulcus, or if complete pars plana vitrectomy has been done, in the pars plana. Okay, rush through. So this is the major difference between a valved implant and a non-valved implant. Okay, the major risk of hypotony, what you see with non-valved implants, is because of the larger surface area of the plate. What is the surface area of AGV? What is the surface area of RD or bowel implant? So it's a large surface area, right? So that is why you have, so they came out with modifications with these implants so that the risk of hypotony comes down. That is what is newer implants. You can rush through that. So Ahmed implant is a valved implant. So they have come to modify it and created a non-valved implant. It's called Clear Path. Comes in two, exactly like bowel implant, 250 and 350. Okay, do you see the difference in the shape of the implant? Yeah, why have they come through that? So that it conforms to the shape of the globe, okay? And you will have a low diffuse bleb. And can you see the difference also? The fixation holes they've made it anteriorly so that it's easier to fixate it to the sclera. And you can see that there is a blue thread-like thing, right? It's a proline suture. It comes pre-threaded because it's a non-valved implant. You don't want early flow. So it comes with a pre-threaded 40 proline. And they also give a 23 gauge needle for entry.
iWatch is a first adjustable device. A pressure control is achieved by selectively compressing its deformable tube by means of an internal rotating magnetic disc. iWatch pen is the control unit of iWatch implant. One side, the compass measures the iWatch's position. The other side, a magnet which adjusts the opening or closing of the valve. So iWatch pen can be turned to position 0, which indicates the valve is fully open, to position 6, which corresponds to the maximal resistance to flow, by dragging the magnet.